everybody. I'm Laurie Gilman. I'm owner of Bookshop. Thank you for coming out this evening and being with us to discuss challenging pregnancy and the larger issues that it brings up. And we also thank everybody for joining us virtually as well. We're really happy to be hosting events in the shop again, and we're glad to have a way to offer them virtually as well. If any of you are interested in more author events, take a look at our website. We have many events most of the time. And we have, our website, I should say, is eastcitybookshop.com. I'm a little out of practice in this. We have an events calendar there, and you can also find a different variety of ways to shop with us. You'll also find information on our 13 different store-sponsored book clubs, the majority of which are still meeting virtually. A couple are meeting in person. We also send out an e-newsletter a few times a month, so sign up for that if you're interested. And we're on all the social media, so look for us there, and you will never miss a thing happening here if you do all those things. Before we get started, just a couple of little things to go over. If you're attending online and you have questions for our author and moderator, please put those in the Q&A box. And we will have one of our staff members, I'm going to read them when we are in the Q&A portion. So please, Q&A box for your questions. And if you have any technical issues, put that in the chat. Okay, now on to the main event. Author Genevieve Grabman works as an attorney during the day. Her night job is being mother to 4 children. She has a master's in public health from Johns Hopkins University and a JD from Georgetown University. She volunteers her expertise in public health policy and refugee law to organizations working in Afghanistan, Malawi, and Mexico. Genevieve is also a 2022 DC Commission on the Arts and Humanities Fellow. Dr. Peggy Ye, who's with us tonight, MD, is an obstetrician practicing obstetrician gynecologist. She's a graduate of Case Western Reserve University School of Medicine, and she moved to DC to complete a fellowship in family planning, during which she earned a master's in public health from Johns Hopkins University. Her current practice focuses on providing comprehensive reproductive health care to her patients. And that is just a very short version of the resume of both of these women, so they can talk more about many of their other experiences. So please welcome Genevieve and, well, Jenny and Jenny, I guess.
Thanks. Thanks for coming and showing up. This is really fantastic. It's the first time I've actually seen, human beings with respect to this book in, ever. I haven't done a single in-person event, so this is really exciting. And thanks also for being online for those of you who have joined us online. I'm excited and also saddened to have to talk about my book at this time. Excited because it's great to write a book, and this book was very much it wasn't a labor of love. It was a way of trying to put down on paper all the research that I had to do to be able to save a wanted pregnancy, and all the work that I had to do to fight against anti-abortion politics and bias at that time to be able to save my pregnancy. And I'm saddened to have to talk about this at this time because we are about to lose those protections we had for the healthcare that I ultimately did receive. And when we lose that healthcare, when we lose those protections, specifically those rights to reproductive healthcare, abortion care that are protected by Roe v. Wade, we know that that case is going to be overturned by the Supreme Court. I don't think there's a whole lot of hope that it won't be. So when we lose those protections, then the challenges that I faced 6 years ago are going to be ever more pronounced, and they're going to be faced by every pregnant person in the United States, especially those who are living in states that don't provide protections for abortion care and for larger reproductive health care. And they're going to have implications for things that we might not have even thought of. They're going to have implications for medicine that is going to affect people who are not pregnant and who don't even want to be pregnant. But for example, will you be permitted to take cancer drugs or tuberculosis medicine if they affect your fertility, or perhaps if you are pregnant, if they would affect your fetus's health? Would you be permitted to take those after those falls? What about genetic testing? If you are pregnant and you're curious to know if the fetus that you're carrying has some sort of genetic disease, perhaps so you could prepare for that, will you be permitted to have amniocentesis for CBS because of the risks those procedures might have for fetal health? Will you be allowed to do that after row falls? Dubious. What about any of the other procedures that Dr. Ye will describe in better detail about general uterine healthcare, right? Anything that gets something out of your uterus that's not supposed to be there. Are you going to be, will your physician be allowed to treat you for your bleeding or for whatever else you have, for your polyps or for your endometriosis, using certain techniques and tools, or will those also be prescribed? These are the things that we're talking about when Roe falls, and this is why we are so concerned, especially in DC, which already has an extremely high maternal mortality rate, meaning that people are dying because of pregnancy-related causes here in our city at much higher rates than we see elsewhere in the developed world, elsewhere in the United States. And in fact, the maternal mortality rate of DC looks like someplace where I used to live, like in Kyrgyzstan. Do we aspire to be Kyrgyzstan? Or do we aspire even to be even less than Kyrgyzstan? Do we aspire to have the same mortality rate as what we're seeing now in El Salvador, where even intervention into ectopic pregnancies is prohibited because they too have strict anti-abortion rules and laws, where the woman has to, or the pregnant person has to explode because of the ectopic pregnancy before doctors are allowed to intervene. So those are unfortunately the things that we want to talk about today, and to think about, okay, what's next? What did I learn from going through what I did, and what's next for all of us? So I'd love to do that. More.
So as the lovely introduction, I am a practicing obstetrician gynecologist here in Washington, D.C. And so I do full spectrum OBGYN care. I see patients in the office. I help deliver babies on labor and delivery. I help do emergency surgeries for anything that comes in the emergency room. I was on call last night, which is why I'm free here today. And I also, as part of my office practice, provide abortions and miscarriage care in our office. And it, I think that in some ways we are lucky in DC in that, the control that we do have allows us to be fairly liberal in what we're able to do. You can see some of the contrasts in care, compared to Virginia. Where the laws are not so liberal. And, it's really, I think it's really, really concerning to think that that's going to be the case and to a much more drastic degree in many places across the U.S. When Roe is overturned. I think they currently 22 states already have pre-existing bans that will come into effect once the decision is released. And then I think there's another 4, so that's over half the states then that have trigger laws that will then go into effect the moment Roe is overturned. And of course, there's large geographic areas that those states are located in. And so now, places that have a little bit more liberal laws are, trying to plan how we're going to take care of these additional patients. Just a little, like a description, kind of, part of some of the difficulties. I was just thinking of, I saw a patient today who was a teen and is pregnant, doesn't want to be, thought she was, maybe about 4 months along, went to a clinic close by in Virginia, which has, I think, a 24-hour waiting period, as well as like a parental notification law. Her parents know, father's involved at least and supportive. So that's thankful. And she ended up being further about 5 months into the pregnancy. Didn't know that. And so they had to go somewhere else. They came to a place in DC that's recently made a lot of news because they've had a lot of protesters. And for a 16-year-old girl, that's crazy. Yeah. So they went there and they just, it's too much, too much. So then they found their third place. And this is somebody who lives across the river in Virginia. This is now their third place that they're going to. And now their care has been delayed by probably 2-3 weeks. And so this is local, right? Someplace that's very accessible. There's plenty of providers in DC and Northern Virginia as well as Maryland. And so it's just going to be really hard to anticipate what's going to happen. Of course, there's a lot of things, a lot of people, grassroots movements, funding organizations that are making that movement and trying to help organize. But I think that it's ridiculous that we're crowdfunding everybody's healthcare, right? People who have insurance were already paying for it. And now we're still crowdfunding like everything, right? People who are getting emergency care, accidents, burns, everybody is out there trying to get money. I mean, the healthcare system is just so broken.
I wanted to riff a little bit on that because it's also, it's one of the little vignettes that I described in my book, and I want to recognize my friends who are here because the vignette happens to feature one of them. Because so the storyline, so you don't have to read, 200 pages of it, is that I got pregnant with what I thought was a blighted ovum. Like I just thought it was a pregnancy that didn't take. I show up at the doctor's office, my lovely OBGYN, to get the blighted ovum just like scraped on out with a procedure that's still allowed. And I find out the doctor looks in, one last time and says, "Oh, whoops, it's not a blighted ovum. In fact, it appears to be two. It looks like you're having twins, but something looks really wrong." And so I sat up, dropped the F-bomb on her, had to write a note of apology, profuse apology, because one should not swear at one's OBGYN. And then that was like off to the races. So from 8 weeks, I knew something was really wrong. By the way, 8 weeks would have been after the time I could have been doing anything about that pregnancy in Texas. And already at 8 weeks, we could see that this was not great. By 10 weeks, I knew that what the problem I had was something that was called twin-to-twin transfusion syndrome, where one fetus pumps away all its blood to the other fetus. They're considered conjoined twins, but they're not conjoined in that like an arm or the head or the leg. Their blood vessels have conjoined across the amniotic sacs. And so that means it has an 80% fatality rate if it is not treated. And it can be fatal not only for the pregnant person, because you can ultimately bleed out because of all this cardiovascular stuff that's going on with the fetus. If the fetuses survive, they're usually extremely mentally compromised because they have not had sufficient, one has had too much blood, another's had too little blood, and nothing has developed correctly. So it's a pretty grim scenario. And so I spent then the remainder of my pregnancy between 8 and 35 weeks trying to figure out what to do about this. And I explored trying to get fetal surgery ultimately. So intrauterine fetal surgery, where a doctor takes cuts a small hole into the uterus and pops in a little scope and a little laser and tries to cauterize the blood vessels that have connected one twin to the other twin. But although the doctor suggested that this was the best care for me, that I should have this surgery, this fetal surgery, to try to save both twins, or at least to save one. And if we couldn't save both of them, or at least one, to save me. Although the doctors recommended this surgery, it was blocked by ultimately 3 different hospitals because there was a concern that it would ultimately result in the death of one of the twins, and so it would be procuring an abortion. And so I was not permitted to have that surgery, and I had to wait until the very end of my pregnancy to find out who would survive it. Like, would we walk out of the hospital with one person, with two people, with three people, or with no people? It was like a fun and exciting lottery. But here's the story I really wanted to tell. There was still an option for me. At around, I don't know, it was after 20 weeks. The surgery or the pregnancy was not looking good. It wasn't looking like it was going to, that either fetus was going to survive. I had been blocked from getting the one thing that might have saved them both. And so, and I had been discharged from a secular hospital to where my maternal fetal specialist, health specialist was, which is at a Catholic hospital. And so there are rules in Catholic hospitals. They apply even to doctors who just happen to have rented office space on their grounds. And that doctor could not tell me that, barring fetal surgery, the next best option for me would be to terminate the pregnancy. But his medical ethics demanded that he tell me that. And so he pulls me aside into a hallway. So he was technically outside his office. And he whispers to me that perhaps I might want to terminate this pregnancy. And, but it was too, he couldn't do it there. It was too late to do it anywhere else around. And there was one place in Gaithersburg, Maryland, that could do a later term termination at that time. And he could make some calls for me and help me, or pass me a phone number. And because he couldn't make the calls from the office, but I'd have to go pass by a bunch of protesters to get there. And I might want to think about that. So I came home and I called my friend Jen. And I was said, and she had no idea about all of this until I told her. And she just sat there and she listened to like another insane phone call that she got from me. And at the end of the phone call, all she said was, I'll go with you. I'll walk with you past the protest. And that remains like, I mean, that's in the book. That remains like the nicest thing anybody has ever said to me. And so it also remains the thing that each of us is going to have to do now. Post-row, we're going to have to be there. We're going to have to walk with people past the protesters because that's the only thing that's all they have left. They have nothing left to help them. And so the fact that we're asking this of our people in the United States, that we're forcing them to give birth in desperate situations, that we're forcing them to walk past the protesters, that we're denying them the care that their own physicians recommend them, that we're forcing them to be dragged into hallways and have them whispered in their ear and transported across state lines and their care delayed by weeks as they, continue to grow a pregnancy that they do not want or cannot bear, physically or mentally. This is insanity. And I wonder why we are permitting this to happen. Because it's not right. So, I mean, I wonder what's going to become of us in DC, though, if because the way the winds of Congress blow, that's how we determine what we have here. So if Congress becomes Republican, they will restrict abortion access in the District of Columbia and all those other medical procedures that I described. And that, they don't have anything to do with reproduction. So, I don't know. What will happen? What do you think?
Right. I mean, we Congress has meddled in our affairs before, for many things, but also for reproductive health care for a brief period of time. We were allowed to use the funds raised locally for Medicaid. So Medicaid funding, part of it comes from the local state, part of it comes from the federal government. And most states are allowed to use their funding to provide for funding for abortions for the Medicaid population, if they so choose. There are about 17 states across the US that do that. And for a brief period of time, I think it was like 9 months in like 2009 to 2010, DC was allowed to use our own funding to provide abortions as part of Medicaid coverage. And then Congress negotiated that and got rid of that. And so since then, we've not been able to have coverage from that. So, right, I think it is potentially only a matter of time. It's really hard to think of that as, the absolute doomsday scenario, because right now DC is indeed actually quite friendly. As I mentioned before, we don't have any parental notification laws. There are no set in legal writing gestational age limits. So for complicated pregnancies in the third trimester, for late diagnoses in the third trimester, patients do have the option of traveling to DC and getting their procedures done. And so that may be a problem. The other thing that we've kind of started to worry about is that that will impact the broader healthcare access for all OBGYNs is training, medical resident training. And so there, for people who are trained to be physicians, they have to go through 4 years of medical school. And then for OBGYNs, an additional 4 years of residency training. And about half of the residency training programs are in those 22 to 26 states that are likely going to ban abortion. And we've already had conversations with Texas residents trying to figure out how they can travel here, where they're going to get the funding to be able to travel to places where abortion is still legal, to be able to get training in those procedures. But if that's 50% of the residencies, the other 50% can't take on everybody. There's an enormous cost. And we don't have that infrastructure. So that's the other kind of challenge that, teaching institutions and training programs are trying to figure out.
Yeah. And I mean, it's not, and again, let's think about this. It's not just about abortion, right? So if you are not trained to terminate a pregnancy, and if you are not trained to do like a DNX and a DNI and a DNE and all the different ways that you can get stuff out of a uterus, how do you adequately manage miscarriages? How do you adequately manage, I don't know, even blighted ovums? How do you adequately manage endometriosis? How do you adequately manage anything that could go on with anybody that has a uterus? There's basic uterine care that is effective here. And similarly, so, I mean, we're not even talking about things like fetal surgery. Okay, that's what I needed. I wasn't like, in the end, I wasn't trying to terminate a pregnancy. And in the end, I didn't have to like get a blighted ovum out of me. I was trying to save a wanted pregnancy, and I needed fetal surgery that was prescribed because of the risk that from one fetus, from separating that fetus from the other fetus. Is fetal surgery going to be permitted anymore? And then what about all this stuff? I mentioned genetic testing and I mentioned all the other things, but if you're not training physicians in the full, I guess, course of what they need to know to be a skilled OB-GYN or a skilled maternal fetal medicine practitioner, then we are going to have people without the skills to treat whatever comes up, because we don't plan our medical crises. They just occur. So, I mean, we're really stirring a soup here, and I just don't know what's going to become of it. It's really already we're seeing effects in medical training. I did an event for Doctors for America, and we had a Texas OB-GYN resident on, and she was describing how she flew to, I think it was to DC, and like did 2 weeks of intensive training on miscarriage and abortion care, and then flew home. And that's all the training she's going to get on those things. That's it. Do you want her attending you? Maybe it's better than somebody who's had nothing.
And I'll add, with regards to some of the broader aspects of, concern of care, some of these, like the Texas law, it's particularly pernicious because, it criminalizes medical care, right? It criminalizes physicians, anybody associated with potentially procuring an abortion, right? Or referring or anything like that. And so, right, what constitutes an abortion, right? Anything that might potentially end a pregnancy, somebody could say you did an abortion, and then the physician is criminalized, right? They talk about it. Can you mention it? Can you mention that as a possibility? Do you have to whisper it?
You write a book, right?
Right? Or, you leave an anonymous note somewhere.
Yeah, totally. This is like This is just all the Texas law is doing is incentivizing every bad boyfriend that anybody ever had to report them for God knows what. I mean, that's just like complete vigilante justice and domestic violence. And, yeah. Yes. So they were, I mean, I don't want to get in trouble. I mean, you can figure. But yes, so they were it was I started out at a secular hospital. I mean, I bounced all over the place. I started out as a secular hospital, and their IRB or institutional their ethics board had to agree to let me have this surgery because it was considered experimental because of the way that these scopes that were going to be used, these tools that were going to be used. So when it was considered an experimental surgery, and the reason why it was considered experimental is because twin-to-twin transfer syndrome is really rare. And so they don't necessarily have scopes or lasers or cameras that have been approved specifically for twin-to-twin transfer syndrome and or twin-to-twin transfusion syndrome. And so in order for the doctor to be able to use those tools off-label, the doctor had to seek approval from the ethics board of the hospital. And the ethics board of that hospital denied me. Then another ethics board of another hospital denied me. And so finally I found the number one TTTS, twin-to-twin transfusion syndrome doctor in the entire world. And I was down to him. He was the last one. He was my last hope. And I found him because we both have masters of public health from Johns Hopkins. I mean, people who have masters of public health from Johns Hopkins are insanely proud of this. And also we're taught to do, I think, really good research there. So I was researching the heck out of this and I found this guy. And I called him up and he agreed to see me and he looked at all my records and he said, okay, can you get to Miami? And I said, all right, I'll go to Miami. I don't know how long I'm going to have to be there. I'll fly to Miami. I was going to fly to Hollywood. I was going to fly to Houston. All right, now I'm flying to Miami. So I'm ready to fly to Miami. And then I get a call from him and the hospital ethics board there denied the surgery. And he was so angry that he quit. And he moved to Belgium. So he told me that he was moving to Belgium, where he also had hospital admission privileges, and it was going to take him a couple of weeks to get set up. But if I could follow him to Belgium, I could get my surgery done there by him. And I'm like, and so the craziness in because like I was crazy at this point. I'm like, my French is really bad, but I can learn French. I'll improve it. I have a couple weeks. I'll figure this one out. No problem. I'll go to Belgium and then, I'll learn French. And then it was too late. Then the pregnancy passed the time that I could actually get fetal surgery at all. And so we just had to wait it out. I just don't recommend that course of action. I don't recommend wondering about you or your fetus's survival until the end of pregnancy.
So I'm listening to you describe all the efforts that you went through to get the care that you needed. What kind of support did you have? You're an attorney. You've likely had a job for part of that time.
I'm upper middle class.
What kind of support did you have and need?
I live in the capital of the free world. So let's not this is also why it's important to have, I think, a physician of color who practices in DC, because I had a lot of privilege. Let's call it privilege beyond support. I am married, so I have a spouse. I have a family support is iffy because I have a religious family who would be opposed to the interventions that I was seeking. But I also have the privilege of this color of my skin, which means that I'm going to get better medical attention and have better maternal health outcomes. I have the privilege of relative wealth, meaning that I could seek out the care that I need and pay for it. And I had health insurance to defray many of those costs, although ultimately when the twins were born, I had to sign them up for Medicaid, public assistance, because my bills for the entire pregnancy exceeded $1 million. Um, so also, when we outlaw Roe, when we outlaw abortion, are we going to give everybody $1 million to save their pregnancy? I mean, I hope that's like kind of the plan, right? And then I have the benefit of I'm like exceedingly well educated, right? So I could do that research and I could understand, I could like actually remember my biostats kind of that I took and understand the studies that I was reading and understand what they meant for me and how reliable those studies were and what was a good intervention and a bad intervention for someone in my position. Few people have this privilege, very few people. And I keep saying that were I anyone else in any other time in any other place, I would have not had anything that I had. But in the end, my outcome depended also on luck. And I also don't think that we should be determining medicine by luck. It shouldn't just be the luck of the draw who survives any sort of medical intervention or lack of intervention. We need to do better than that. But yeah, I had a lot of things working for me. And with my first pregnancy, I gave birth in a freestanding birth clinic here in DC. And it was really fascinating because I was one of the few people who carried with me the privilege of my wealth and skin color to that freestanding birth clinic, which is in Northeast Washington, D.C. And the population is by and large African American young women from the neighborhoods around that freestanding birth clinic. And they don't have that privilege and receive excellent care there, but are typically in Washington, D.C. are the population that has a very high risk of poor birth outcomes. And so already we're shouldering people who have a lot of risk with even more risk of not being able to get the care they need or afford the care that they'll require when we outlaw anything that has to do with abortion. Yeah. It was a wild ride.
And here you are.
Do we have questions from the online people as we kind of gather on? Yeah. 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 So, I mean, and this is a little bit dicey because yes, I mean, medical ethics boards exist for a reason. We don't want human experimentation, right, without consent, and um, and so that's really important. And they especially when something is an experimental practice, then that's exactly why they are examining that practice. The problem with ethics boards, though, are let's say you're at a Catholic hospital. They're applying a set of Catholic ethics and Catholic morality, which is different than medical ethics and different than biomedical experimental ethics to your situation. And I, for example, I happen to be Catholic. I also happen to lie every time I go in for medical treatment and I don't write down that I'm Catholic because I'm terrified that if I'm knocked unconscious, somebody will find out that I'm Catholic and apply to me the church's requirements, even if I don't want them for myself. And in a secular society, we should not be held to those. You know, if the church wants to come and get me for something that I have or haven't done, we'll have that conversation. But it shouldn't be in my doctor's office or in the hospital when I need care. So similarly, with a secular place, I would argue that there is bias, and that I do argue that anti-abortion bias has tainted medical ethics in a lot of these ethics boards, and certainly the ones that I encountered because I had I found the best people, the most highly educated, the most experienced, the most published doctors in the country for the condition that I had. And if they were advising me as to a course of action, I have to presume that they knew what they were doing. And if I chose it with all my ability to choose, then I would have to trust my choice in that matter as well. And my choice and the advice of my physician were respected by the experts that we consulted.
Yeah, so this is kind of a good little segue into some of these like political interferences, right, into these medical decision making between a patient and her physician. I mean, you should be in control of your own body and what happens to it, and have a choice in what happens to it, including the pregnancies that you had that you were gestating. But here is something that you agreed was the best course of action for you and your family, with the hopes of, treating and, the best favorable outcome for the pregnancy. You had a physician who thought that that was a acceptable, good course of action. And then there's a third party there who's saying, oh, no, we don't think so. Can't do that. So, I think there's not only in politics, not only in Congress and state laws, but even local politics, local policies. And many institutions do have policies that are maybe even more conservative than laws.
Yes.
We haven't been repeating the questions.
So I was just wondering about if you can say some more of the specific differences in, say, Virginia and DC as far as what's available, because I feel like this whole discussion, not here, but in the general society about abortion and women's reproductive rights is very broad, and details like what is and is not accessible are really eye-opening. And I had just never thought about the fact that right across the river is there's not the same kind of availability for healthcare. So I was just wondering about some of the other differences.
Yeah. Sure. So I don't practice in Virginia, so I don't have as much expertise about their abortion laws. But I do believe, and also things have changed, right? Because a couple of years ago, before Terry McAuliffe, like the entire state legislature and the governor was Republican, and so they had a lot of laws that were really restrictive. And then, there was a Supreme Court decision with Whole Women's Health that allowed limitations to some of those laws. And so Virginia, under Terry McAuliffe, was starting to backtrack some of those laws. Now, of course, Glenn Youngkin is the governor, and I'm not really sure where we are with that. But in general, Virginia does have a 24-hour waiting period. And this is pretty common amongst many conservative states across the US. Yeah, so it can vary a little bit. So a patient has to have some sort of consultation 24 hours before she can come in for her abortion. Now, some places it can just be a recorded message. So you call into the clinic, they play the recording, and then that counts. Some places, so I trained in Ohio before I came here to DC. In Ohio, it had to be in person, face to face, written, and with the same physician who is going to do your procedure. Because, like when you're on labor and delivery, it's exactly, you definitely get you only see the one OBGYN, you only get that one person to do your procedure the entire pregnancy, right? Yes. So, but it can vary. But that's how it can look like. So some places can be as, unobtrusive as just listening to a voice recording. Some places do require it to be face-to-face. Couple of other states require 72-hour waiting periods. That's a 3-day, and they exclude weekends. Because, you can't think about things on weekends, only during business hours, right? Not that waiting periods have been shown to change anybody's minds, but apparently, right? I want to live in that world where I'm only,
Data on that.
Right.
They do nothing.
Exactly. Sounds great. So I think Utah has like a 72-hour waiting period. A couple of other states do. So I believe Virginia's is 24 hours. What else? So there is a minor like parental notification law. And that's also common in many places. They always have to have some sort of judicial bypass. So if you're saying that you're a teenager or a minor and you don't want your parents to know, then some places are really strict. You have to have a reason why you don't want your parents to know, meaning they could actually physically threaten you, harm you, or be the person who got you pregnant. And so you have to be savvy enough to, request that and then go to court. And then the court has to approve the judicial bypass for you to not have to notify your parents. Some places actually require parental consent. And I can't remember what states. Guttmacher is a really, really great research organization that does a lot of, they have really quick fact sheets about a lot of state policies. So it's my go-to place. But yeah, so they do have a parental notification. Now, sometimes parental notification can be as easy as, all right, you give me your parents' like address and we'll like send a mail, to them to let them know. And that serves as, notification. So sometimes it can be easy as that, but sometimes it can be as onerous as like actually getting written consent from them. And then as far as gestational age limit, so that's another really common law across the US. And it's based on Roe v. Wade. So Roe v. Wade had set what they call kind of like a trimester framework, where as you get further in the pregnancy, the state has a little bit more right to control abortion, and potentially even to the point where they can ban abortion after viability, with exceptions for maintaining maternal health. And so some places have placed bans at viability. Now, this Roe versus Wade never really defined a gestational age for viability. Back in the 70s, it was probably around 26, 27, 28 weeks. Now, with the medical technology and progress that we've made, it can be considered as early as 22 to 23 weeks. Generally now considered probably 24 from those places. And so there are states that ban abortion at viability. And so Virginia, I think, is one that may be, so that would be about 24 weeks. But there are places that have banned at 20 weeks. And of course, now, everywhere else is jumping on the bandwagon and banning at 6.
So, yeah, and that's one of the things that I also keep pointing out. Like, when I was talking about terminating my pregnancy, or when my physician, whispered in my ear, I was beyond 20 weeks, but I had extremely compromised twins. Nobody was viable. That was kind of the point, that like the pregnancy wasn't going to be viable. And so instead of caring to term a non-viable pregnancy and birthing dead babies, then maybe it would be better to end that and to reduce the suffering. And the whole sort of concept of hardlining in law when there's a presumed viability for all pregnancies does nothing for people with challenging pregnancies, and certainly for people who are carrying multiples, where the age of viability is definitely not at 20 weeks or at 22 weeks or even at 24 weeks, just because the fetuses are in a much less developed and more compromised state. And so that again shows the sort of the fallacy of trying to legislate reproductive health, because reproductive health happens to be a rather individual thing. And maternal health is always very individual. Fetal health is very individual. And so if you try to legislate it and you have an inflexible law, it means that law does not work for the people for whom it's regulated. It's nonsensical, because there's simply no viability for that pregnancy. Again, you can tell the people that are writing these laws have no knowledge about maternal or fetal health. And that's their ignorance is showing.
Thank you so much. I also want to plug the group marker. Like I work in this space, and so I like using their tracker. They have a yes, yeah. So if you go online and you can look at their tracker for, they do it by state, and so folks from all across the country, they can always go there, as it's a super reliable, always up to date resource for both medication abortion and for the clinical in clinic abortions. I wanted to ask if you could tell us about what happened, like, or I don't know if you wanted to like give away the ending, but I kind of gave it away. I like as you heard, I was like, what happened with the pregnancy? And could you like tell us about, you know, what happened and how what that was like for you navigating that, you know, that whole process and how you're feeling now?
So the spoiler is that I didn't die. So I'm still here. Nobody died in the making of the pregnancy or the writing of this book, with the exception of a potential parasitic triplet. That yes, we even had maybe one of those. That's a story for the book. Yeah, because of course, if anybody would have had a parasitic triplet, it would have been me. And also, yeah, what do you do about a parasitic triplet? People writing these laws. And so, yeah, we did not die. I was given 24 hours to give birth. I started being scanned since I couldn't get the surgery. The only thing that doctors can do in that situation is they monitor you. And so they were monitoring me every 2 weeks, and then every week, and then every day. Yeah, you go in, you get a fetal echocardiogram. So you get like a Doppler. They use a Doppler. It's like the coolest thing. You can like tell the weather with it, and you can also like watch the blood go back and forth between your fetuses with it. It's amazing. And then I was also getting ultrasounds, and yeah, that costs a whole lot of money. That's how I spent it all. Um, and So every day, and then my yeah,
I was like, that's why you're writing this book, right?
Well,
You gotta
oh,
make
yeah.
pay off those bills.
making tons. You know, people are just lining up to purchase a book about reproductive rights and twins, but twins, great twin stories. Everybody likes twins. And so then I was given 24 hours. The doctor said, if you wait longer than 24 hours, the small fetus is not going to make it, and he'll pull down the larger fetus, and you will have two stillbirths. But there was a problem. You can't just show up and give birth, like, you know, wherever, especially if you have a highly compromised pregnancy and you're expecting that the babies have a long NICU stay. And so you probably are going to want to give birth someplace that can handle that if you want to have a good outcome. And the trouble was that the place where I had, like, you know, booked my birthing spot, like, you know, a responsible person, and the OB that I was going to have deliver me was presently actually giving birth to her own child, because I was 6 weeks early, and we thought we had timed it that she could have her baby, have her ample 6 weeks of maternity leave unpaid from her hospital, and then, because she's an OB, and then be back to deliver my babies. But a wrench was thrown in that plan, and I had to find a hospital that I could go to, like, frantically. So I'm calling all the hospitals in the DC area that also have a NICU, and just trying to find a slot and anybody to deliver me that, oh, by the way, can like handle this. Oh, because I also wanted to give birth to vaginally, and one of the twins was breech. And so like at this point, I was one of those. And so then this is the other great story from the book. My maternal fetal specialist was the former medical director of a Planned Parenthood location. And did all the abortions west of the Rocky Mountains for a very long time. And because he knew how to terminate a pregnancy, he knew how to save one. Because the flip side of destruction is creation, always. And so he canceled his vacation with his son, and he agreed to attend me. And he got me a space at the Catholic hospital for his son. He's like, "You're gonna be okay." That had a NICU, and he attended me, and I had a non-medicated vaginal birth of one of the twins. And then I was induced. It was horrible. I don't that just is awful. I was induced. I had a doula because my husband doesn't do childbirth, and so he wasn't even in the building, and he couldn't make it. And and I had a whole medical school, like an entire medical school class that was in for the show. And then when I started hemorrhaging after, because I was induced, first baby came out after like 8 hours or something, 12 hours of labor. And then there was no second twin and no second twin. And you know you're in trouble when the following happens. Two obese, they put on the splatter shields. They go spelunking up into my nethers. And then they're feeling around trying to find the other twin. They kind of grab him, he swam away. And then all of a sudden I looked down and I noticed they were covered and like splattered with blood. And the doctor just shouted, like, to the OR. And they like stopped doing what they were doing and they wheeled me down to the OR and gave me an emergency C-section. I was very conscious. Yeah. So then the second baby was born via emergency C-section, and he was born. I birthed one baby that was very dark with blood, lots of blood. That would have been the recipient twin. The donor twin, he was born in respiratory distress. The donor twin was born stark white. He was 2 pounds, 15 ounces. He didn't make it to 3. He was stark white. He had no blood. He actually was in better respiratory condition than the larger twin. They flashed him at me and they ran with him to the NICU, where they soon gave him the first of 3 blood transfusions. And they were both born with holes in their hearts. The larger twin had to go on a vent. The smaller twin ultimately also had some respiratory things. They had jaundice, one from too much blood, the other from too little blood. And the little guy really had it the worst because he got sepsis. He had something. He stopped breathing a few times. I had to resuscitate him. I got to watch that on my birthday. He actually stopped breathing and coded on my birthday, and he turned green. And I sat there because I'm a lawyer. I had the sense of mind that I might have to sue somebody about this, and so I recorded it. It's on my cell phone. I recorded the whole thing. As they ran around, they had a cracked manual resuscitation device. It was cracked. The bag was cracked, so it didn't work. So then they were trying to run around to find an electronic one. The battery was dead, and they finally found one. Yeah. And babies can actually go without oxygen for a while. It's kind of impressive. And so they brought him back. And I told the guy, I was like, if anything happens to this kid, I got the evidence. Yeah, they're mostly fine. Yeah, everybody's mostly fine. How long? They're 6. And they're beautiful. Like they might, there's a little bit of a, I don't think they're going to be rocket scientists, but they're really good looking, and that gets you really far in America. Yeah.
So the question is advice from your book about somebody trying to navigate their own challenging pregnancy.
So I don't think it's fair to ask every single person to do the amount of research that I did, because ultimately that research consumed a book. I mean, that's an unfair ask. I would say, though, that I learned that the research that I did was fairly critical because I was able to find the people that were able to help me. And that's why I list all the resources that I do in the back, so that people could perhaps draw upon those if they wanted to. I mean, Group Marker is in there as a resource. But the larger thing is everyone says seek second opinions, seek third opinions. And again, that's also an unfair thing to ask because people only have so much money, and your second and third opinion, by the way, is paid for off of insurance. So you can't seek a second and third opinion unless you have the wealth to do that. So if those are not within your capability and you're not within most people's capabilities, then I would continue to just keep asking questions. When somebody says it's against the law that I do something, like, I can't help you because it's against the law. Press back and say, is it really against the law? Or is it just the policy at this hospital? What if I go to a different hospital? Or are you uncomfortable, you doctor, doing this? Would a different doctor be able to help me differently? Keep asking those questions, because people often say, especially non-lawyers, they say things are against the law, and they often are not. So I would not let just somebody telling you that something is prohibited, impossible, illegal, even after Roe, right, Paul? Even after Roe. Just don't assume something can't be done, but constantly just say, are you sure? Is this truly against the law? Is this truly against policy? Is this truly a restriction? Is there truly nothing that can be done? Because it might be that through that course of questioning that you find out there is another path. And that relieves you also from having to pay for second and third opinions, or, the trolling gentleman that line.
I'll agree. I think that kind of persistence really pays off. And, for somebody who is educated, knowledgeable, and has resources, and has the confidence to be able to ask those questions, I think that's helpful, but not everybody is like that, including me, actually. And so, yes, you should be that difficult patient if that's, in your wheelhouse. But also I think finding a team that you trust to help you guide through the decisions, help make referrals, help think about options, help cancel their vacations with their sons so they can deliver you. Finding that right team is really, really important. And that's hard to do. There are a lot of physicians. There are a lot of reviews. Some are good, some are bad, some are kind of crazy. But finding the right team and staying with them and asking your friends is also, I think, one of the best ways to kind of get started on the right foot.
So you talked about how intense the monitoring was and the expense of that, and how much you had to really push your medical team. How much did you have to push your insurance?
Oh my gosh. Yeah. I know that you're. So yeah, I'm like, this is the one benefit of being who I am. Like, I'm good at pushing insurance, and I do. But I'll say though that insurance, insurance plans and people who, and even your insurance connection in your HR department at your job, those folks are also affected by anti-abortion laws and anti-abortion politics. And so at my job, when I went to inquire about what was my coverage for pregnancy termination and also for fetal surgery, my person in HR who is supposed to be in charge of telling me about health insurance told me that I should pray to Jesus and refused to tell me what my insurance benefits were. And that was kind of a presumption because she had no knowledge about my belief or lack of belief in Jesus. And I will also say that bad things happen to people who pray very well to Jesus. So, and you can also even when you call up your insurance, it might be that the person on the phone doesn't know or refuses to tell you about care that person personally opposes. And so I encountered challenges throughout in trying to figure out what my insurance would actually cover. And I will say though that, this is my one little nugget that I leave people with. If you have a challenging pregnancy and you ultimately give birth to kids who have a lot of needs, medical needs, that there is something called the Katie Beckett waiver that I wish more people knew about. And that allows the children to get public assistance where it is available. It's not available in many places, but it is available in DC. And if you can get your kids public assistance through Medicare, through this Katie Beckett waiver that doesn't count the parent's income against the child's eligibility for Medicaid rather, that was a huge game changer for me because that allowed me to get, for example, dedicated nursing care, especially for my smaller twin who was really compromised. And we had a team of nurses that wound up living with us for 8 months. So, and that would have never been possible had it not been through the grace of the U.S. taxpayer and through my finding out about this waiver to permit you to get your children to get Medicaid. So that's also, it's a wonderful thing, and more people should take advantage of it.
There's certainly a lot more to be discussed, but thank you both so much for being here. Thanks everyone for joining us and coming out. And the book, Mike, can you hold the book up again just so it's what we got to talk about. Challenging Pregnancy. We have them available here, and I'm sure that you'll sign some books if anybody would like that. You're an author. That's what you do. That's what you do. And again, there's just so much to think about here. And I just hope that you will go out from here and have these conversations with people who, for whom it will be important. And thank you again for being here.